Thank you for the introduction, and thank you very much to Professor Slade for inviting me to contribute to the afternoon. I have a story to tell about a failed patient safety intervention, and while failure of itself can often be frustrating, there were some great lessons that I learned about organisational culture, which I quite enjoy, and I'm happy to have the opportunity to share some of those lessons with you guys. The problem that my initiative was attempting to resolve or help to ameliorate is medication error. And the image here shows 5 ampoules, which appear quite similar, but are actually very different in terms of their class of action and their effect on patients. And so what we want to avoid is the anaesthetist picking up and administering the wrong medication, which can potentially have catastrophic results. A corollary of that is that most medication errors won't in fact have a devastating impact on the patient, and most medication errors will actually go unacknowledged, which is part of the problem, because if it's not clinically significant, then the temptation is to ignore that it ever happened. And if a medication error happened in an operating theatre and no one saw it, did it really happen? And in that regard, most of them probably don't. So it's no harm, no foul, nothing to see here, nothing to do. And this can lead to a tolerance of near misses or a tolerance of erosion of standards, so-called normalisation of deviance. And that's a term that came about from the NASA inquiry of the Challenger disaster. And there's a culture of a gradual acceptance of deteriorating standards. Do we tolerate these near misses, or do we bother to acknowledge them and investigate them and try and improve our standards of care and practice before waiting for a catastrophe? I'm so sorry, there's the image. And there's a number of reasons why a doctor or anyone who's made a mistake would not want to have that mistake publicly acknowledged. And while there may be at the larger end of the scale some financial impediment to wanting to acknowledge a mistake, most of the barrier probably relates to our reputation and the fear of negative judgment. And the good, as in a good doctor, relates as much to character as it does to capability. And there's definitely a moral judgment that we make about someone who's made an error. Are they up to the job? Can they stand the heat in the kitchen? There are some intrinsic questions that are raised when someone acknowledges that they've made an error. Are they clumsy or careless? Do they deserve to be in the role where they are? And the traditional responses to a voluntary admission of a mistake is something along the line of you put them in the stocks and everyone gets to boo and hiss and possibly throw some fruit. And then the public shame and humiliation is a warning to everyone else that mistakes aren't tolerated. It's not good enough, don't do it. And as a result of that, mistakes continue to occur, of course, but they go under-acknowledged. And this under-acknowledgement has been investigated in the literature, and there's an interesting paper here, which shows that if we survey anaesthetists, approximately 1 in 5 will acknowledge that at some stage in their career they've made a mistake. However, if we look at other ways of investigating the incidence of errors, and we look at databases of self-reports, incident reporting, it looks like about 1 in 200 anaesthetics, so 1 in 200 patients, will have a significant medication error as part of their care. And in large databases, drug errors are about 10% of the incidences that are reported. However, if anaesthetist practice is directly observed, about 5% of drugs that are administered will have an error attached to them, either due to a dose or a timing error. As I said, not all of these errors will be catastrophic, but errors are common, whereas the acknowledgement of them is not. Now, our college has produced guidelines to help reduce the incidence of medication errors, and there are some nice human factors engineering solutions in terms of the layout of the medications. You try and minimize what's in the trolley, minimize the number of medications that are there that you can make a mistake from, organize them in a logical way so the drugs of the same class are ordered together, and try not to put things that look the same together. And a big part of these human factors engineering is standardizing the layout. So no matter what operating theatre I go to, I'm seeing the same drugs in the same layout. So that if the operating theatre is busy and I'm distracted, or it's dark, or I'm hungry, or I'm stressed, the chance of me picking up the wrong medication and making an error is vastly reduced. And the recommendations are supported by the literature and expert opinion. And as PowerPoint presentations go, that was the burlesque approach. Just a hint, just a glimpse to tantalize and excite you for what's to come. And what it's all about is reducing the latent factors that predispose to an error. Fallibility is part of our human condition. We're all prone to making errors. We all will. But we want to reduce the likelihood that it occurs. And if it does occur, reduce the likelihood that a patient will be harmed as a result. So what I hope I've been able to convey is that medication error in anaesthesia is common, that it's hazardous, that it's potentially catastrophic, but there are simple solutions that we can apply that will help to reduce either the frequency of an error or the size of an error in terms of clinical impact. And so this is the challenge that I faced in the ACT when I was trying to attempt this intervention. These are the medication trolleys in different hospitals. There's about 100 anaesthetists in the ACT, and we'll move between hospitals commonly. Certainly on a daily basis, we'll be in a different hospital, but we can move between 3 hospitals in one day. And so wherever we go, we've got to reorientate ourselves. What's here? Where is it? And hopefully we're not bothered by any stressful circumstances, and we're able to go about everything in a civilized fashion and reduce the chance of there being an error. So I got in contact with the directors of each of these hospitals, and they all thought it was a good idea that we should standardise the layout. And it took us a few months to coordinate what was going to be in the trolley, rationalise that, and then to have it all organised in a nice logical layout. It took about 3 months of negotiation and several iterations to get that process about right. And that's all going well. So then I emailed my colleagues to let them know about the intervention. And then this is some of the feedback that I got from there. And there's a lot of commentary there. It's free flowing. It's reply all. Everyone can see everything that's happening. And most of it says, there's no problem. What are you doing? You're an idiot. Everyone hates this. Oh, yes, evidence from evidence. And so that gave me cause to pause and reflect. And one of the things that I've learned during my studies is how the science of implementation has evolved over the years. In the olden days, what used to happen is someone did some research, they published it in a journal, and then you wait for something to happen. And that takes a long time and it doesn't work very well. And then the situation evolved to getting experts and clinical leaders to producing systematic reviews and clinical guidelines to help people make decisions and informed best practice. However, there are problems with generalization of guidelines, and often people aren't obliged to follow a guideline or even recognize it. And so that can be ineffective as well. And more recently, there's been a trend towards industrial style or business research-led models, like continuous quality improvement. But the problem with medical care, some of which Walter was talking about this morning, is the intrinsic complexity and inherent uncertainty in it. And that doesn't necessarily lend itself to compatibility with industrial models. So the latest thinking of the way to correctly implement an initiative is to follow a systems engineering approach, which means that we need to coordinate all the different players, which is a much bigger undertaking, and because it involves getting people to cooperate and collaborate. And that's where culture comes in. Anytime you want people to follow a similar path or a similar purpose, there needs to be a cultural element. They need to have a similar mental model that they can pursue and to help guide them and help motivate everyone to work together. And without a cultural basis for the improvement initiative, it's very hard to get people to cooperate and collaborate. We tend to all operate in our own silos, and I'll do what's best for me at this point in time for my patient, and everyone else can do their thing. So what is this organisational culture that we're talking about? Culture overall is an abstract concept. It's difficult to put it in a nutshell what it is. It doesn't come in a fortune cookie. And to understand it, we're really got to understand how pervasive and broad it is. It's an underlying force that in any organization or any group of people will tend to influence behavior in an unconscious way. It is useful because it facilitates purposeful group achievement. It enables behavior which we consider to be desirable for the function of the group, and it discourages behavior which we consider to be undesirable. The culture develops when groups solve problems together, and it evolves gradually. And it's as much influenced by that bottom-up evolution as it is by top-down management decisions and priorities. And the real power of culture, the way that it influences our behavior, is in the peace and tranquility of a shared mental model. When we're able to be in a group that's working together to make an accomplishment, it's very socially rewarding. And it brings us peace and tranquility. And that's the motivation and the power of culture. And Edgar Schein described a layer, or the 3 layers of culture and how to think about it. And at the top of the iceberg, you can see here are the visible artifacts of culture, what we can see, what a building looks like, what a uniform is like, what are the normal processes of care that people follow. These are the visible manifestations of culture. And sometimes you'll hear culture described as the way things are done around here. And that's it. That's the tip of the iceberg. Underneath that, in the second layer, are the espoused values of the organization. So who we are, what we stand for, what we want to accomplish, what's our place in the world, what are we all about? But underlying that is the real essence of culture, which is the basic assumptions, which is our unconscious perspective, how we interpret what's happening. It directs what we pay attention to, how we feel about it, how we respond to it, and it's coherent with the rest of the iceberg. So that if you try and tinker with the top, it's hard to make much of an impact without understanding or knowing what's going on with the rest of the iceberg. So in that context, I offer an understanding of my colleagues' reaction to my initiative, which seems irrational. But the essence of culture is that it's so deeply ingrained in us. If it gets challenged, the challenge can be met with a response which is emotional and irrational. It's very hard to try and pick apart someone's culture and say, why do you believe that? What are you all about? They're likely to react in a discongruous way with the attempt to whatever you're trying to do. And just to reassure you that I'm a little bit on the right track with my interpretation of the events, this is an article from Anaesthesia and Intensive Care from last year. The authors reviewed medication incidents from WebAIRS, which is our college's incident reporting system. And they found that we have failed to effectively address the problem of medication error in anaesthesia. And what we need to fix it is strengthen the current focus on safety culture. And that's a wonderful idea. So we'll go and get some safety culture and we'll bring that in, and then everything's fine. The problem with that is what we've just described is the essence of culture is in the bottom of that iceberg. And how can you tinker with that? And that's the challenge for us now if we want to progress and implement another patient safety initiative, is we do need to affect that cultural response to what we're trying to do. And the way we intend to go about that in our organisation is firstly assess the status of play. And we do that with a patient safety survey. And the 8 shops or hospital survey of patient safety culture has been used for decades. It originates in the US. Last year, it was recommended by the Australian Commission as the recommended tool for surveying patient safety culture. And all hospitals and healthcare organisations had their approach to safety culture assessed as part of their accreditation requirements. And so it's likely to be something that we'll see more of in the future. And it's a 35-question survey, which goes to all staff, clinical and non-clinical, and it gives us an idea of what are their perceptions of the patient safety culture in the hospital. What are the strengths? What are the weaknesses? What are the opportunities for improvement? And putting out that survey can, of itself, without doing anything else, improve the safety culture in the hospital by raising people's attention to the opportunities for iatrogenic harm in the organisation, and for also alerting to people to what are the priorities of the organisation, and patient safety is now one of them. And then the intention is to follow that up with a team steps, team building and communication program, which aims to not only to address people's communication and teamwork skills, but to direct them to the science of patient safety, the basis for how errors occur and how we avoid them, and to give them the skills to be able to identify their own problems and initiate their own patient safety intervention. Because when you're trying to change culture, no single intervention will work on its own. It needs to be done as a coherent program. So this program has got some executive buy-in, and it'll be happening concurrently with other programs like Speaking Up for Safety, which is a graded assertiveness program, which is intended to reduce the hierarchy gradient and enable people to be able to speak up when they do see a patient safety concern. And that's how we intend to grow our safety culture and hopefully facilitate future implementation of patient safety initiatives. Thank you for your attention.